Morning, friends. So we were talking about actually the post-operative complications of cataract surgery. Okay. To recapitulate what was done, what we have talked in the last class is, pre-operatively the patient may have anxiety, nausea and gastritis, allergic conjunctivitis and corneal aberration. Regarding this, actually we have already seen. And this is a retrobulbar haemorrhage which can occur as a complication of retrobulbar anesthesia in cataract surgery. Nowadays we are not doing it. We are not giving actually retrobulbar anesthesia. It's only peribulbar anesthesia. And oculocardiac reflex, perforation of the globe, subconjunctival hemorrhages, spontaneous dislocation of the lens, all these things, they are common with as complications of the anesthesia. And during the surgery, there can be superior rectus laceration and hematoma, excessive bleeding. Okay. So the superior rectus laceration and hematoma will occur when we are passing a superior rectus bradal suture to have the globe in the downward and fixed position. And while you are cutting the conjunctiva, there can be an excessive bleeding and it can be cauterized. And if the incision at 12 o'clock, from 10 o'clock to 2 o'clock in case of extracapsular cataract extraction, and from 2:30 o'clock to 9:30 o'clock in case of actually intracapsular cataract extraction. If it is irregular, it can give rise to actually a defective coaptation of the wound and also in irregular astigmatism in the post-operative period. And injury to the cornea while you are entering the anterior chamber with 11 blade at 12 o'clock position, inadvertently you may hit actually the posterior surface of the cornea, giving rise to a Descemet strip. And if you go down a little, you may injure actually the iris, giving rise to an iridodialysis. And sometimes an accidental rupture of anterior capsule can also occur. And vitreous loss can also occur. This is a very catastrophic complication because it should be dealt with very, very carefully. So the causes for how to decrease actually vitreous loss on the table is actually initially prior to the surgery, we are supposed to decrease the vitreous volume by giving the patient a mannitol 20% solution, 1 gram per kg or kilogram body weight intravenously, and or glycerol. We can give actually 2 ounces 3 times per day for the day before the surgery. And to decrease the aqueous volume, actually we give astazolamide 250 milligrams, 2 tablets the night before and also on the day of surgery. And better ocular akinesia and anesthesia will have to be achieved by a proper block and minimizing external pressure over an eyeball. When you inject actually intraocularly or intraorbitally, the anesthetic drug, naturally there will be a little proptosis, the globe becomes very tense. So you will have to rather do the massage so as to reduce the intraocular pressure to around 16 millimeters, so that we will be very comfortable while doing the surgery. And it should not be too soft also, or it should not be too tense. So with experience, actually, we get what sort of intraocular pressure or tonicity we should have actually while doing the surgery. In case of actually myopia, there can be a scleral collapse. So as to prevent that, we use actually Flieringa ringa. And so consequences of vitreous loss, actually, the vitreous actually comes and touches the iris. It can give rise to vitreous touch syndrome, and vitreous wicks can as well go into the incisional line and give rise to defective coaptation and also a mood leak in the post-operative period. Or vitreous, it can block actually the pupillary region, giving rise to a pupillary block. Direct contact of the vitreous with other structures, with these structures always it will be difficult for the patient to maneuver, rather manage in the post-operative period. Incarceration of the vitreous into the operative wound, it gives rise to, as I told you, there will be a problem in wound healing, and there will be defective coaptation of the wound, and also the patient will have an irregular astigmatism in the post-operative period. And fibroplasia of the residual vitreous occurs, and inflammation of the vitreous occurs, which gives rise to a vitritis, and finally it may lead on to actually an endophthalmitis. Excessive degree of astigmatism, as I have already told you. And suppose if the vitreous comes and touches the cornea, there can be bullous keratopathy. If it is managed with the treatment, with the medical management, it's fine enough. Suppose if the bullous keratopathy actually proceeds unattended, the patient may land in for actually a keratoplastic. Epithelial invasion in anterior chamber can also occur. So suppose when there is actually vitreous in the anterior incision, so the conjunctival epithelium, it grows through the breach in the incision and goes onto the posterior surface of the cornea and also onto the iris, and it gives rise to epithelial ingrowth, and it can cause actually secondary glaucoma, and intractable glaucoma can occur. And fibrous ingrowth also, it causes an intractable glaucoma. And sometimes, suppose if the wound is infected, so it may lead on to actually an endophthalmitis, a catastrophic complication in the post-operative period. And whenever there is vitreous disturbance, and vitreous is there actually in the anterior chamber or in the section, so there will be an updrawn or misshapen pupil. And fibroplastic traction bands can also form in the vitreous, and secondary glaucoma, which is recalcitrant intractable, can also occur. And these people, they are not found for actually cystoid macular edema, and vitreous opacities and vitreous hemorrhages, they occur. And expulsive ciliochoroidal hemorrhage is another thing which can occur after vitreous PC rent and vitreous prolapse and all these things. And fibroplastic condensation of the residual vitreous occurs, and this leads to actually a retinal detachment, and the vitreous in the anterior chamber touching the other important structures will definitely lead to an ocular irritability. So how we manage actually vitreous loss? Recognition of dangerous eye prior to the surgery is most important. Suppose the people who had previously a vitreous disturbance, are the people who are having low scleral rigidity, the people with the high myopia, all these people actually, one will have to be with the people with vitreous syneresis, liquefaction of the vitreous. All these people actually, they will have to be a little careful. We will have to be a little careful prior to doing the surgery. So the lack of scleral rigidity, as I have mentioned, inherent weakness in the anti-hyaloid membrane of the vitreous is also another thing actually which can predispose to the vitreous prolapse. Pseudo exfoliation of the pupillary region and also the anterior capsule is another condition where actually there can be vitreous prolapse because the pupil will not be dilated and there will be joint adhesions also in these cases. So when we are removing the nucleus, the vitreous can prolapse. And preventive measures are to reduce the aqueous volume and also vitreous volume prior to the surgery. Suppose if the vitreous has already prolapsed into the anterior chamber, we do an anterior vitrectomy by doing an open sky anterior vitrectomy or pars plana anterior vitrectomy, so which solves the problem in most of the cases. Suprachoroidal hemorrhage, we have talked about it. Expulsive ciliochoroidal hemorrhage. This is another thing which can be given as a short notes for you people in the examination, maybe 4 marks question. So it is Wengel in 1786 who has first promulgated and has first pronounced this entity of post-operative cataract formation. Usually the short posterior ciliary arteries are implicated, and expulsive ciliochoroidal hemorrhage or expulsive ciliochoroidal hemorrhage, it occurs in 1/3 of the cases during the surgery, 1/3 immediately 3 to 6 hours after the surgery, and 1/3 7 hours to 9 days after the surgery can also occur. Clinical picture, what will happen is actually when we are doing the surgery, the section starts opening up despite of us, and the globe actually becomes very tense and very hard, and the section opens up, and there will be structures, intraocular structures, which will be coming out of the pupil. Initially, the aqueous, vitreous, and lens, and next actually a gush of blood finally. And when you look at actually the clinical picture or the eye after an expulsive ciliacardial hemorrhage, it looks like this picture. Okay. And prophylaxis, so whenever you think actually there can be actually an expulsive ciliacardial hemorrhage in the particular eye, so this is most commonly seen in people with atherosclerosis and hypertensive individuals, and also usually in case of filtration surgeries. When we are doing a filtration surgery, these things, they are more common. Okay, hypotensive agents such as mannitol, glycerol, all these things can be given. Vasodilators can be given. Ascorbic acid along with routine can also be given. Hyperosmotic agents and digital pressure, these things will have to be done, and the eye must be reasonably soft. Around 16 millimeters of mercury intraocular pressure is ideal. And on the table, suppose if we see actually this expulsive ciliacardial hemorrhage is imminent, in such conditions, what we do is we remove the superior rectus suture and also the speculum, close the eye, and put the pressure till everything settles down. Okay. So normally we review the case the next morning, but usually in expulsive ciliacardial hemorrhage, the morbidity is very, very high, and the patients, they lose the eye. Suppose another thing which we can do on the table is actually we can give bolus mannitol to reduce the vitreous this thing again, or tap, suprachoroidal tap can also be done so as to reduce the expulsive choroidal hemorrhage consequences. Early post-operative complications, I have already told you, hyphema is the most important thing, and this can be given as a short notes. And suppose if it is mild, moderate, or total hyphema, the complications of total hyphema unattended is a corneal decompensation, a blood staining of the cornea, necessitating a keratopathy can occur. And this can give rise to actually secondary glaucomas. And iris prolapse, suppose if it is a fresh iris prolapse, we abscise we deposit back actually the iris. And if it is an old iris prolapse, we abscise the iris and put a suture at the particular place. So iris prolapse can also be given as 2 marks question. And striate keratopathy is another thing which commonly seen. It's a grade 4, grade 1, grade 2, grade 3, grade 4 also can occur. And grade 1 actually there is it occurs and it disappears in a span of 7 7 days or so. And grade 2, 3 actually the intraocular structures, the iris and all these things, they will be easily seen. And so we give estrazolamide 250 milligrams thrice daily, and also we give cyclopentolate, and we give hypertonic saline, hypersol, all these things thrice daily, and that helps actually in reducing the haziness of the cornea or striate keratopathy. Suppose if it is grade 4, these people, they will not respond to the medical treatment, and there is a considerable loss of endothelial cells, and we'll have to go for a keratoplasty. And flat anterior chamber, we have already seen wound leak, ciliocoroidal detachment and pupillary block with this thing, vitreous bulge. All these things, they can cause this thing. Bacterial endophthalmitis is another thing which can be given as a short notes question for you. So the incidence is around 0.06% to 0.235%. Source of infection is surgeon's respiratory tract. We have already talked about it. Airborne organisms in OT and also indigenous flora. So risk factors for post-operative infection are poor hygiene, prolonged operation time, and also an unplanned ECCE and debilitated immunosuppressor individuals and the people who are on immunotherapeutic drugs, these people, they are more prone for it, corticosteroids and all these things. So the signs and symptoms, they depend upon actually virulence of the organism and also size of the inoculum, and the time actually at which the patient presents with the symptoms. If he presents with immediately, the prognosis is definitely better. But these people, they present in, say, a week or 10 days after the occurrence of endophthalmitis or starting of endophthalmitis, which necessitates actually removal of the eye or enucleation. Okay. Time of preoperative state of the eye is also important. We'll have to look for actually any focus of infection anywhere in the vicinity. And the surgical trauma while we are doing the surgery should also be reduced. And local and systemic defense mechanisms against the organism will have to be assessed. And prior administration of the antibiotics. Normally, we give preoperative antibiotics the day before, for fluoroquinolones, moxifloxacin or ditafloxacin 6 times per day the day before the surgery. And also on the day of the surgery, we give the same antibiotics 2 hours prior to the surgery, and also instill povidone in 5% solution into the conjunctival sac about an hour prior to the surgery or an hour prior to the surgery. And that helps actually in reducing the incidence of this thing, endophthalmitis. So clinical features actually depend upon actually whether it's a bacterial endophthalmitis, fungal endophthalmitis, or sterile endophthalmitis. So usually the clinical features are the patient is good immediately after the surgery, bacterial endophthalmitis. The vision is good, but 2 days or 3 days or 48 to 72 hours after the surgery, the patient may come back again stating that he has got pain and redness, and also the vision has come down. So when you examine actually the patient, there will be actually a conjunctival congestion, circumciliary congestion, and the AC will be, there will be hypopyon, corneal edema will be there, and there will be a yellowish fundal glow. Okay. So that indicates actually that the patient has got most likely an endophthalmitis. What we do is we make an aqueous tap and also vitreous tap and try to inject intravitreous injections, vancomycin and also ceftriaxone, along with corticosteroid, dexamethasone. And we review the case again after, say, for 24 hours. Suppose if it is improving, then we can re-inject actually intravitreally the same drugs. Suppose if it is not improving, better send the case to the vitreoretinal surgeon for the eventual core vitrectomy or total vitrectomy, pars plana total vitrectomy will be done. Endophthalmitis prevention. So that's how actually we do this thing. So cystoid macular edema is another late post-operative complication. So in 1953, Irving has first diagnosed a case of cystoid macular edema. And Gas Norton 1966 is the first person. These are the people actually who have put forward the fundus fluorescein angiography findings of cystoid macular edema. And clinical features are sudden onset of congestion will be there. The patient will complain of photophobia, that is intolerance to the light. And central vision will be lowered. The patient will not be able to see the central vision. There will be a scotoma. And when you examine the patient, actually there can be an aqueous flare and spontaneous rupture of anterior vitreous face of the hyaloid. Anterior vitreous face will be seen. And non-surgical treatment of cystoid macular edema is one is topical steroids and Sub-tenon injection of deposteroids or posterior Sub-tenon injection of suppressors. Posterior Sub-tenon injection of deposteroids can be done. Oral steroids, very rarely we use it. And topical anti-prostaglandins such as keratopathy or nepafenac, all these things, they can be used for nearly about 3 months. And suppose if there is actually vitreous incarceration, Laser-yag vitreolysis can be done. And surgical management, normally what we do is actually in these cases, suppose if there is a vitreous disturbance, vitreous strands are there in the wound or anything, we can do as well do a vitrectomy. Let us see another thing. So this is in the complication actually. Wound dehiscence can occur in the immediate post-operative period and also in the late post-operative period. And it is quite uncommon in cases of actually tunnel incisions, in small incision cataract surgery, and also in phacoemulsification, where you have actually sclerocorneal tunnel. So this wound dehiscence is very, very rare, and can be due to a defect in the tunnel architecture if at all it occurs. And defective wound healing and our lens or iris in the wound, so it inhibits the normal healing process of the wound. Okay, so late wound healing, late wound leak, actually it is mostly because of the trauma, and spontaneous loosening or breakage of the previously put sutures can also give rise to sometimes a late wound leak. And there can be actually tissue melting and necrosis. Suppose if we put very tight sutures, there can be necrosis of the wound margins and melting of the tissue melting can also occur. And that can give rise to a late wound leak. And so wound leak, actually what clinical features will be, the patient will have a flat anterior chamber. So flat anterior chamber, and when you do actually a CDLS test, so there will be dilution of the aqueous in the particular area in the incision. So that indicates that the patient has got actually a wound leak. Immediately in the post-operative period, normally we put a pressure bandage and review the case after 24 hours. And if the chamber actually forms again, then there is no problem. Otherwise, we take the patient to the theater and put a suture. In these cases, normally we decrease or discontinue steroids for some time. Prophylactic antibiotics will be given. Pressure patching, as I have already mentioned. Collagen shield and bandage lens are disposable soft contact lenses. Okay, bandage contact lenses or disposable soft contact lenses can also be used. And if it doesn't come down, the chamber doesn't reform, in such cases, we resuture the patient again. So this is actually the picture. So an inadvertent filtering pleb can occur in the post-operative period, early post-operative period. Medical measures such as patching the eye and reviewing it after, say, 24 hours normally solves this problem. Late blebs reflect breakdown of a well-opposed wound. So it may be because of the trauma or suture breakage or loosening or scleral melting. And suppose if the patient is asymptomatic, we just can observe this filtering bleb. We need not actually do anything. If it is causing irritation and tearing and also infection, the bleb will have to be excised, and the defect can be reformed with an amniotic membrane. Large thin-walled blebs predisposed to the endophthalmitis. So a surgical excision of the bleb along with rebuilding the deficit, if at all it is present, defect in or gap present in the 12 o'clock position, it will have to be reclosed, redone, or it will have to be managed with an amniotic membrane graft. Blebs normally they induce against the rule astigmatism. Okay. Options, there are different options actually which we have for late closure of the wound leak. So one is cryotherapy, and secondly a chemical cautery with trichloroacetic acid, and an argon laser can also be used, and surgical closure with suture. And blood-induced endophthalmitis, always it is present. The risk of blood-induced endophthalmitis is always present. So the patient must be on frequent follow-ups, and if at all if you have any doubt, better actually intervene and remove the excise the blood and reform it actually with amniotic membrane. And epithelial ingrowth, we have already talked about it. So most commonly seen in case of intracapsular cataract extraction, small incision cataract surgery and also phacoemulsification, it is very, very rare. And surface epithelium, conjunctival epithelium, they invade the intraocular tissues, covers the cornea, the posterior surface of the cornea, iris, ciliary body, and also the lens capsule. What it can cause actually a corneal decompensation, chronic uveitis, and intractable secondary narrow angle glaucoma. And so the confirmation is by specular micrography and histopathology of the tissue, and treatment is destruction of the epithelium, which is ingrown into the anterior chamber by cryotherapy, iridocyclectomy, and pars plana vitrectomy. Post-operative astigmatism, less with scleral or limbal incisions than with corneal incision. For small incision cataract surgery, superior temporal incision causes less astigmatism than the incision at 12 o'clock. From an incision along the limbus, actually it gives more astigmatism, and the chevron type or frown type incision actually gives less astigmatism. Smaller incisions induce less change in corneal contour than more stable refraction than larger incisions. Sutureless incisions not usually associated with significant wound-related flattening. And sutures, the wound induces more astigmatism. The suture, especially in case of intracapsular cataract extraction and extracapsular cataract extraction, where we put the sutures nearly about 5 to 8 sutures, so that causes more astigmatism. We sometimes suppose if the astigmatism is more after 8 to 12 weeks after the surgery, we do actually selective suture manipulation, which reduces the corneal steepening, and also it reduces the astigmatism. Corneal steepening with the rule astigmatism, it is caused mostly by tissue compression and over-tight sutures and vertical wound malalignment, and cautery, excessive cautery, which causes actually the burning and charring and gives rise to tissue contraction. Corneal flattening are against the rule astigmatism. It is caused by actually wound gape, unsutured wounds, and loose sutures. And what we do in these cases actually is a cheese wiring knot or slippage. So these are the things which are done, and it reduces. Irregular astigmatism, it is caused by non-adjacent sutures, which are really over-tightened. And post-operative astigmatism persisting after suture adjustment may require surgical correction. So suppose even if you do actually the sutural adjustment and the astigmatism, be it with the rule or against the rule, it persists. In such cases actually, we revise actually the original incision, or we make actually arcuate incisions either with the laser or with this knife, and this is separate corneal refractive procedures. That's what we do. And corneal edema and bullous keratopathy is another complication where the patient might be having actually prior endothelial disease and also cell loss. And intraoperative endothelial cell loss is more in these cases. And excessive post-operative inflammation can also lead to the corneal edema and bullous keratopathy. And prolonged post-operative elevation of intraocular pressure is another cause actually for corneal edema and bullous keratopathy. And late onset of corneal edema can occur many years after the IOL surgery. Excessive loss of endothelium at the time of surgery, followed by ongoing normal or accelerated damage or attrition of the remaining functional endothelium, so can give rise to late onset of corneal edema. Anti-chamber lenses, which are placed in, is a major cause of corneal edema. The AC lens may be loose, and closed loop AC lenses have a much higher rate of late corneal decompensation. And treatment of corneal edema, initially we will have to eliminate the cause which is causing the corneal edema. The first and foremost is treat the inflammation and iritis with steroids or whatever it is. And in the immediate post-operative period, suppose if during the surgery, if we don't actually aspirate the vitreous, viscoelastic material immediately prior to closing the wound, so that viscoelastic material may clog the trabecular meshwork and may give rise to actually rise in intraocular pressure. So, so that we will have to aspirate all the visco which is present during the surgery. And secondly, we should see that actually there is no vitreous disturbance. Suppose if there is a vitreous bulge and pupillary block, that also can give rise to a rise in intraocular pressure. So suppose if there is a rise in intraocular pressure, we give anti-glaucoma medications to reduce intraocular pressure. And suppose if the IOL is in contact with the any structures, say angle or whatever it is, so that also will have to be tackled. Hypertonic agents such as hypertonic saline, hypersol, 6%, 5% solutions are there. And these things actually, if instead, the corneal edema will come down. And the pain will have to be dealt with in these cases with lubricants and soft contact lenses and cautery of the Bowman's layer. And a conjunctival flap can be covered over this thing. And for restoring actually anatomy of the cornea, which is not amenable to the aforementioned treatment, so we do a penetrating keratoplastic. And late hyphemas and microhyphemas actually they are caused by chopping of the IOL against the iris or ciliary body. That's UGH syndrome which occurs. This is typically occurs when there is a loss of fixation of sulcus fixated IOL. Okay, treatment is IOL exchange with scleral fixation or an AC IOL. Chronic IOP elevation can be because of actually a corticosteroid use, or chronic inflammation, chronic uveitis, all these things. And retained lens matter, particularly nuclear fragments, and peripheral anti-astigmatism formation, a ciliary block, and correct diagnosis of the cause to institute therapy is mandatory. IOL miscalculation can also occur. I think I have not told you about actually the IOL calculation. The IOL calculation normally we do with the formula SRK2 formula. So P is equal to A minus 2.5L minus 0.9K. We'll come to that later. Suppose if there is a miscalculation of the IOL and the wrong power of IOL is put, we'll be forced to do actually in a we'll be forced to expand the IOL and put in a correct IOL. Okay. Asymmetric haptic placement, I think this is not necessary for your people. It's only for extremely common occurrence with a open capsulotomy. That is, say, not not actually a CCC, a can opener. Suppose the patient becomes actually symptomatic if the lens is decentered relative to the pupil, and there can be actually polyopia, glare, induced myopia because of the edge of the lens, and the loss of best corrected visual acuity. The visual corrected acuity will not be come back to the patient's satisfaction. So in such cases, actually, when the lens is decentered, we give myotics so that the edge of the lens will be covered by the iris. And IOL repositioning can also be done. Suppose if it is not possible, we'll do an IOL exchange. There are certain complications actually which are really frustrating and demoralizing the ophthalmic surgeon. Even after doing actually an uncomplicated cataract extraction, we face with a disappointing visual outcome. So those complications are cystoid macular edema, age-related macular degeneration, and periretinal fibrosis, and macular holes. Okay. And cystoid macular edema, we have seen about it, the most common cause of unexpected visual loss of after cataract surgery. And fundus fluorescein angiography shows in about 50% of the cases in the post-operative period at 4 to 8 weeks. But clinical CME usually occurs in about less than 3%. And time of onset of clinical CME is 3 to 4 weeks post-operatively. And predisposing factors for cystoid macular edema are PC rupture and vitreous loss, iris incarceration in the wound. So suppose if there is a prolapse, there is a vitreous subthrust and iris prolapse, and it gets entangled actually in the wound, it can give rise to a, say, cystoid macular edema in the long run. Anterior vitreous adhesions and also incarcerations can give rise to actually cystoid macular edema. And pupil irregularity and pupillary capture of IOL in the post-operative period, iris distortion by IOL, and anti-chamber inflammation. So all these things actually they can give rise to cystoid macular edema. So this is actually vitreous tag is there, and the pupil is updrawn like this, and pupil peak rather by vitreous band. Okay, so that can also give rise to this. So clinical signs of cystoid macular edema are there will be thickening of the macula, and there will be perifoveal splinter hemorrhages will also be there, and central foveal cysts can be seen, and subtle surface wrinkling of macula will also be seen, and accentuation of the yellow xanthophyll pigment of the macula will also be seen in these cases. So the treatment of post-operative cystoid macular edema is, step 1 is topical corticosteroids, prednisolone 1% or dexamethasone 0.1% 4 times daily, or topical NSAIDs such as ketorolac or nepafenac. All these things can be given. And step 2, a peribulbar steroid, Sub-tenons injection, posterior Sub-tenon mostly, it is more efficacious. And step 3, a carbonic anhydrase inhibitors, 250 milligrams thrice daily can be given. Surgery, YAG vitriolasis or vitrectomy can be done to treat actually post-operative CME. Chronic endophthalmitis, we have seen actually the endophthalmitis occurring in the immediate post-operative period. This chronic endophthalmitis can occur very late in the after surgery. It is normally caused by organisms low virulence such as Propionobacterium acne and Staphylococcal epidermidis. These two things actually can give rise to a chronic endophthalmitis. It may present actually in many ways. Chronic mild granulomatous or non-granulomatous uveitis can occur, and white plaques on the lens capsule. So can be seen on a routine examination with slit lamp biomicroscopy. Onset, it can be months or years after the surgery, and cases appearing after YAG capsulotomy may be the plaques can be sequestered in the capsular bag. So patient may or may not complain of actually pain in the orbital pain. Okay, the vision will be blurry, and variable signs are there, and conjunctival hyperemia occurs, and when we can see with the slit lamp keratic precipitates, And hypopion will also be there. And when you examine actually the vitreous, there will be vitritis. Other offending organisms besides the aforementioned two, we have staph species and actinomyces. This also can cause actually chronic endophthalmitis. Posterior capsular opacification is another thing actually, which is a complication which occurs in the immediate late post-operative period. Time when actually it opacifies, it is variable depending upon the surgery, depending upon the age of the patient. And significant opacification occurs from months to years. So in almost all the cases. In younger age group, the opacification is almost 100%. Rate of opacification actually declines with age, as in the elderly age group actually after the surgery is done, rate of opacification is less. In congenital cataracts actually the posterior capsular opacification is more. Posterior capsular opacification is caused by proliferation and migration of residual lens epithelial cells. So they form either Elschnick spells or a capsule transforms into a fibroblast on posterior capsule, or it can be a Sommer's ring. So for posterior capsular opacification, what we do is we do YAG laser capsulotomy. So again, the patient will see normally, and the patient will have actually good vision. And careful assessment is necessary prior to know whether the PCO is the only cause for actually decreased visual acuity, or whether there is any posterior segment abnormalities which are contributing to the fall of vision. The so-called posterior capsular YAG laser posterior capsular capsulotomy is done. We'll wait till nearly about 6 months after surgery before doing actually posterior capsulotomy. So contraindication for YAG capsulotomy are absolute contraindications are corneal scars, irregularities, and edema that interferes actually to place the target on the laser beam onto the posterior capsule. And relative known or suspected cystoid macular edema, active intraocular inflammation. And when there is actually a high risk of retinal detachment, we don't do it also. So the assessment of significance of corneal capsular opacity, we do a distinct direct ophthalmoscopy, and a retinoscopy can also be done. Red reflex evaluation by slit lamp by microscopy, and fluorescent angiography to rule out any retinal pathology. And posterior capsulotomy technique, normally a minimal energy will be used. 1 millijoule normally it is maybe sufficient. We cut across the tension lines usually and perform a cruciate opening. We begin at 12 o'clock and go up to 6 o'clock, and again we start at 3 o'clock and go to the 9 o'clock position. And this is how we do it. This is how actually it is open. This is how it's open, and this is again like this, and this is again like this. Okay. After posterior capsulotomy with a YAG laser, we normally give anti-glaucoma medication to reduce intraocular pressure, and cycloplasics also for 3 to 5 days, and steroids we give for about 3 to 5 days. Retinal detachment is another late postoperative complication which can occur. Incidence is around 0.2 to 3.6% after extracapsular cataract extraction, and incidence is around 5-fold after intracapsular cataract extraction. So the incidence of retinal detachment after small incision cataract surgery and also the phacoemulsification has come down. The predisposing factors are prior YAG capsulotomy is another. When the axial length of the globe is more than 24.5 millimeters or 25 millimeters, in high myopic individuals, pathological myopia with lattice degeneration, or retinal holes, or retinal tears, all these things, and intraoperative complications leading to vitreous loss, and posterior vitreous detachment is another thing actually, which these are the predisposing factors which can give rise to retinal detachment. So besides these complications, so there are some more complications which are common with every type of surgery. Okay, these are the these are the complications which occur, which are common with every type of surgery, and there are certain complications which are specific with certain surgeries. In case of intracapsular cataract extraction, so the incision is a very big one, and there can be actually a post-operative incision-induced astigmatism. And again, the sutures will be actually nearly about 6 to 8 sutures normally we put. Incision is a very last one. And there can be suture-induced problems such as suppose if the suture is loose, there will be a wound leak. And suppose if the suture is very tight, and there can be local necrosis and giving rise to wound leak later. And there can be, suture is always an aedes for infection. So this causes actually, this may lead to a sutural abscess, or this may go on to actually an endophthalmitis if the sutural abscess is not properly dealt with. Okay, and the problem with phakic glasses, we have already mentioned, we'll come to it later again. And in case of small incision cataract surgery, so when we are entering, actually making a sclerocorneal tunnel, so there can be buttonholing of the scleral flap. And secondly, there can be a premature entry into the anterior chamber. So these are the complications specifically connected to small incision cataract surgery. And when you are doing actually a capsular rhexis, the capsular rhexis either can be a small rhexis or a large rhexis or an escaping rhexis or an eccentric rhexis. All these things, they can occur. And when you are, in case of actually phacoemulsification, the lens drop can occur, which is really unforgiving. So with the other types of surgeries, normally we don't have a lens drop. Sometimes it occurs, but it's very, very rare. So in the next class, I think we talk about the various types of IOLs, and also we go on to actually the congenital cataract surgery. Congenital cataract and surgery. Okay, so all these things we'll see. Any questions? I'm sorry, I think you are not able to see the slides. I don't know what to do, because we are, the person actually who takes care of it is not around. Next time, within a quick succession, I think I'm going to show you the slides, and that will solve the problem. Okay. This is the problem actually. We don't know what you are seeing and what you are reading there, sitting in your places. If it is actually in the regular classroom, I think everybody is alert, and we can know what you are seeing, and we can know what you are hearing and what you are doing. I don't know what your name is. Your number is flashed here. I'm really sorry for this mishap, and we'll see in the next class definitely. Okay, we'll take care of it. Thank you.